Welcome all again to our next webinar that is on Pediatric Spondylolysis by Dr. Jwalant Mehta. So Dr. Jwalant Mehta will be joining in a while, but this is a very interesting session after all our sessions on various pediatric spine problems. And after discussing the first webinar, which was on pediatric back pain, you all know that pediatric spondylolysis is one of the most commonly seen problem in our day-to-day practice. So before we go ahead, I would also like to discuss with you all that we have our next webinar, which is a very interesting webinar for all our surgeons, spine surgeons, and neurosurgeon colleagues, where our webinar is on neuromuscular problems, that is specifically meningomyelocele in pediatric spine problems by Dr. Bronick. So let's go ahead till Dr. Mehta joins. We'll start the discussions with how and is pediatric spondylolysis managed in our current scenario in the Indian population. We have an interesting presentation by Dr. Nene. Is my screen visible?
Not yet.
Now?
No.
Okay. So let's start with the case. We have a 19-year-old fast bowler came with left-sided low back pain. His performance was affected. He was not able to bowl as fast as he can. And when he comes to us, this is what his examination looks like. He is able to fully flex himself. His extension is mildly painful. There is some painful rotations as well. And we can specifically check tenderness in our back or in his back whenever we do deep palpation. So to all the pediatric spine academy faculties that we have here from various parts of the country, the first question that comes up is how commonly do we see these kind of patients in our practice? So Dr. Ajoy, how commonly do you see these patients in your practice?
In my practice, it's relatively very less. It's probably because I come from a relatively second-tier city. I think sports is not the primary thing. Therefore, but recent past, in the last, I think 1 or 2 years, 2 to 3 years, we are seeing more and more younger children who are into sports. Either it could be cricket, either it could be badminton, any one of these sports coming with problems related to the back. And also, we are seeing some spondylolysis also in our practice in very young pediatric children who are into competitive sports.
So, other faculties, if they want to add something, are there any other specific sports you feel that is commonly seen where you see these kids? Like one of the thing is cricket, where fast bowling because of the rotational forces. Any other specific sports that come into your practice that you see them?
As I said, I've seen in badminton also, shuttle badminton especially. I think it also involves a lot of extension backward when they are doing a shot. I mean, these are the two categories of patients I have seen, but we do not cater to a lot of sports persons in our area. I think most of the sports persons are based in major cities. Appaji?
Yeah, Dr. Jhala, you need to add. Yes,
yeah,
Appaji.
Yeah, so okay, after that I'll.
Yeah, so what we saw is in power lifters and weight lifters, we have seen in young kids, 18-year-old, 20-year-olds coming. Second group is, as we said, mostly in cricket, only the pace bowlers who have that hyperextension action. The famous bowlers, everybody has had a lysis. The third, we have treated 3 patients, all school children, 15 to 16, equestrian injuries, horse riding. So these 3 patients, we have done 1 football fellow also, we have done all minimally invasive. Now we are doing minimally invasive midline incision buck screw. We don't do that old style pedicle screw with the hook anymore. So these are the 4 sports which I have seen personally is this equestrian sports and the powerlifting, even the girls, 16-year-old, 18-year-old girls.
Amit?
Yeah, so I have recently for last 1 year, I've been associated with Gujarat Cricket Association, and I see the young patients. I've seen, of course, as Appaji said, pace bowlers in peak of their and they are trying to enter the Indian team, and they have these lysis, especially the pace bowlers. Even there are stress reactions that we have picked up before the lysis. Even a female cricketers I have seen with a lysis, and one volleyball player. So these are the 4 or 5 cases that I have seen in last 1 year. All of them have been treated with conservative and rest, and they were okay. Of course, how they have been under rehabilitation program now. They have not gone back to their main sport as on today. So this is my experience.
Okay.
So, yeah.
And
So,
we can. Yes, Hriday, continue.
yeah. So, as we discussed, so it has been acute hyperextension injuries or some movements where there is sudden extension, like fast bowling, or as we discussed, badminton, or where horse riding, where there are sudden extensions that causes stress on the pars, which is something that causes lysis. So this was the X-ray that this 19-year-old fast bowler had, and what we can see is the L5 lysis, which is clearly seen. So the next thing that comes into discussion is, when do we actually go for CT scans and MRIs in such kids where there could be some suspicion of lysis with undiagnosed back pain in pediatric patients, or where we know that these patients have back pain and we have not come into some final diagnosis. So how often and when do you do CT scans and MRIs where X-rays are not found?
I think Amit would be a better person to answer this.
Yeah, so if it's a routine patient, then we will still wait with all the conservative treatment, just get the X-ray done. And if the patient comes back with the routine treatment, and if there is a persistent pain, then we will investigate. But if it's a sports person, we have to do everything in the first go. So then we investigate. We have done PET CT also, as well as CT, as well as SPECT CT, to find out exactly whether there is a stress reaction or not. So it depends on which category of patients that we are looking at. So that is how we follow.
Can I add a point in this?
Yeah,
Yes.
sure.
Yes, please.
Yeah. So there was this lecture in SRS by SCAGS, the UCLA group. They do lots of sports, high-end American football players. So, but with them, they say 60% of these lysis heal. You don't have to intervene even in high-end sports people, but you have to rest them properly and rehabilitate them properly. Then they can go back to sports around 9 months' time. 40% only will require intervention, and most often it is in the form of surgery only. So they are advocating that you should not first, and then they also were telling don't do PET and SPECT CT because it is at that young age it is huge. So they are advocating MRI and then the MRI bone scan. They don't even do a CT scan now. The MRI bone and the MRI scan. So these are this was a lecture by SCAGS in that SRS meeting this year, which I attended. I'm just adding it as a point. Yeah.
So in our practice in Indian scenarios, what would be the preferred investigation if it's a suspicious back pain? Will it be an MRI to see a edema on the parts, or would you prefer to do a CT scan?
So again, the papers say edema in MRI is not a sign of healing or a acute fracture. So you will be confused. So most of the time, what we do is here a SPECT CT only. We have been doing SPECT CT to see if it is hot or cold. If it is a heart lesion, they say if it is a heart lesion, you don't have to operate. You have to wait till it becomes cold if that means it is non-healing. If it is still hot, you should not operate. That is a ultimate thing. Yeah.
So that means you would do SPECT CT twice to confirm that has the lesion become cold or not?
You do a SPECT. If it is hot, you treat them conservatively. You don't go ahead. Yeah.
So now, once we start conserving such patients, so one of the things that comes down to the thing is SPECT CT is something that helps us to know is it a hot or a cold lesion. And hot lesions are something that we preferably conserve because they are acute lesions and they have chances of improving with conservative treatment versus cold lesions that are chronic lesions and they would probably not respond that great with conservative. But we all know that conservative treatments are first line protocols for any kind of lysis. So what are the conservative protocols that you commonly practice?
Before we go that, I'd just like to add, Hriday, like
Yes.
now there is a particular group of people, sports person, very young, who are looking to a career in their sports. And therefore, whenever you see a young sports person comes to you with significant back pain, especially as shown in this case study, flexion is okay, but extension causes you significant pain. If the first line of investigation would be an X-ray, and when you find that X-ray is even negative, it's safer to get an MRI scan, as Amit mentioned, because the whole career depends on that. They would have put years of effort into their career. Before you get an MRI scan, if you've got a good radiologist, it will be easy to interpret whether there is a stress reaction. It's not necessary they can have a pars breakage. Before itself, there could be a pre-break stage where there could be a stress reaction, wherein you may have to intervene to prevent the pars from breaking. Okay, for me, in a patient with a high suspicion, X-ray followed by MRI is the first line of investigation. If MRI shows a break, then we can think of planning whether it's trying to be a healing lesion or a non-healing lesion. Okay, only you should, as Appaji said, you should consider it to intervene. Only there is no evidence of healing as shown in the SPECT CT. Probably Jwalant will give us more information about the use of MRI as to how it's going to interpret MRI to know whether it's healing or not healing. Then only we have to get into the management protocol. Coming to the conservative protocol, maybe Amit would be a better person to answer.
So what, as you said, Ajoy, we first is if there is a stress reaction, we give a complete rest to them. Complete rest means avoid sports. They have to do all modify their activity depending on the pain. So that is how we rest, but the sports activities stop. So that is what we consider rest to the sports person. After that, if the pain subsides, we reevaluate them. If the pain subsides after the rest, then we start with definitely isometric, initially isometric exercise for the flexion extension both. But then going to the flexion exercises more and avoid the extension. And gradually they go for, after that, they gradually go for rehab protocol. In rehab protocol, they will start with, of course, the spinal exercise, but they will even go for, you see, light running and jogging so their endurance increases. So that is how they go. And then they are allowed small sessions of play. That means if they are bowlers, they may be allowed around 2 or 3 overs to and then they take forward. But the whole protocol takes about 3 months time. About 3 months. So that's how we follow.
Do you use any sort of a brace to prevent extension?
We usually don't use a brace to an extension. Extension brace, we don't use it. Okay. But yeah, you can definitely use that, one of the things.
Appaji, you want to add anything in that?
Sir, again, the adequate rest in the initial part, but muscle toning has to continue. So muscle exercises, isometric muscle exercises to continue, no isotonic exercises, strictly no sports and no lifting for the first 6 weeks. Then rehabilitation, they usually heal by 3 months and then they can start sports rehabilitation from 3 months of time. If they are not, we do use a brace, the anti-flexion brace, which is sort of rigid posterior brace in the first month.
Okay.
So what is the take on swimming? Like most kids or most people who come to us, they know that swimming is good for back. So when lysis and swimming, any specific things to add for that?
You can allow freestyle swimming and not the other styles of swimming. Other styles of swimming require extension. Only freestyle swimming you can allow, but in the initial phase, again, as I said, no isotonic exercises.
Okay. So it has to be core strengthening isometric exercises, initially flexion based, going to extension based, and then also concentrating on endurance where it can be light walking, running, maybe some freestyle swimming. So as we discussed, so L5 stress fracture, so these are hot spots that can be seen on the SPECT CT scans. And so 6 weeks of rest for all hot spots, and then we can gradually start light activities and gradual rehabilitation, as we discussed. So bone scan is the first investigation where a hot spot is something which means it's an acute lesion and it needs rest period. Cold spots would probably mean that early rehabilitation can be started and rest can be less as compared to a hot spot. MRI is an investigation which could help us in picking up lysis in parasagittal cuts where we can see edema. CT scans are something that would help us actually know the exact anatomy, and sclerosis or not is something which will actually help us know that are those lesions new or old, and of course dynamic x-rays when we have lysthesis. So when these lyses are not picked on time, this is how we come up with they may progress to lysthesis. And as we all discussed that it in professional sports person, we should not wait to do one investigation after the other, should not waste time. And when we are dealing with professional sportsmen, we need to investigate and do all that we have to come to a diagnosis versus treating patients who are not so professional in their sports, but they are kids who come up with back pains. We can do just an X-ray, start with some conservative management, and then go ahead with other investigations as and when needed. So now comes the question is, we all are surgeons, and when do we do surgeries and what surgery do we do? So to Ajoy sir, so when do you think that these kids or these sportsmen will actually need a surgery? How long a conservative treatment should be given?
Okay. But before we go into that, Hriday, the first thing we should understand this, the incidence of lysis in the literature varies between 5 to 7%. I mean, it's an incidental lysis, which is asymptomatic. There need not be any lysthesis in a very young patient. And if you take MRI or X-rays for thousands of people, you might find a prevalence of lysis around 5%. And usually we do not know the exact cause of lysis, but it usually happens between the age of 5 to 10 years, some part of developmental changes. It can become symptomatic as it progresses to a lysthesis, or when they are 30 or 40 years of age, whenever there is a degeneration of the disc, which can cause symptoms. But what we are discussing here today is basically a sports-related or a pediatric spondylolysis, which is symptomatic following an activity which involves extension or any activity for that matter, which brings about a lysis. Therefore, the management of these group of patients who are symptomatic is different from a management who are child, which you are just look at an incidental finding with occasional back pain or when you take an X-ray for some other reason. Okay. Regarding surgery, again, Amit.
No. So we have not at present. I think my experience for doing a bucks fusion is very less. I think Appaji will be much better person to talk about it. Because I would, if at all required, I'll do a fusion. I have not done a bucks fusion regularly, right?
Appaji?
Surgery, as I said, only in cold lesions. not never in heart lesion, after adequate rest, and only if and most of the time if they become asymptomatic, they don't want to pursue sports, you can actually leave them. If they want to pursue sports and still have symptoms, then you will go fuse. We used to do the old style pedicle hook, pedicle screw and hook technique for long. We have had that first of the equestrian boys we did that. He went to do something but never progressed into full sports. Now we have two football players, one from Bengal and one from Assam. We have done navigated buck screw fusion. So we use the shoulder screw or a full length screw, four screws like our medial malleolus screws, and they are okay. That's the way we are doing now.
I agree with the fact that if you're planning to operate, it should be symptomatic after a period of conservative treatment. But the most important thing when you decide to operate is the fact that you have to look at the status of the disc. Even though there are a lot of papers saying that you can operate, a few papers saying that you can operate on a disc which is degenerated, you basically look at the type of degeneration or whether the disc is Firman's grade 1 and 2 is what is safe. But if you have a Firman's grade 3 or 4 disc degeneration, that means it's already started to collapse. It's not an ideal one. A lysis is safer. You can sometimes extend up to a 0.5 lysthesis, but you have got a grade 1 and 2 lysthesis, they're not candidates. Number 3, you have to, when you get an CT scan done, you have to look at the anatomical variation. If you've got a bifid spine, you've got other features of dysplasia, you might have thought it's an post-traumatic or a stress-induced lysis. Then also, if the anatomy is not safer, then again, you should be very cautious in approaching that. If you've got a gap which is very big, the gap is more than 0.5 to 1 centimeters, they are not ideal candidates for repair because the chance of failure becomes significantly more. What technique you use, it depends on what you are comfortable with. Okay, Bucks is probably the most popular one, but there are many techniques which are equally good with the same outcome. You are muted, Hriday.
So for Bucks repair, is there any specific bone grafting which is done at the site of repair, or it is just the curatagen fusion that you generally prefer?
Appaji?
So what we have done is only like a tube technique or endoscopy technique. We just burred and then put some DBM with bone marrow aspirate in those two footballers and one girl, powerlifting girl. They've shown fusion. One is almost 18 months old now, and the other two are almost 2.5, 3 years old. So they're all doing okay as of now. One girl whom we did the pedicle screw hook almost 6 years ago has actually toppled and she has come with a spondylolysis. We have revised her to a fusion and she has left sports.
What has been advised is basically like you have to freshen that site. Okay. And then you have to pack the bone. That is before the bone bridges. See, actually your screw is going from the base of the inferior articular process across the pars and into the pedicle. Therefore, the part of the bone you are putting is going across the lateral part of the pedicle across the pars defect. You definitely have to curate. You have to pack it with graft, or actually in the Western scenario, in very active professional sports persons, they tend to use BMP also, so that to increase the chances of union.
So recently there has been a couple of things that I saw on the internet and some papers, is that there are a couple of people who use screws and a U-shaped rod that is spaced under the spinous process, which actually cause compression over the parts. So any specific
that's a very old technique, Hriday. So they used to call it smiley rod.
Smiley rod.
Now recently they have been coming up with this a couple of companies. So how is comparing that technique with Bucks fusion? So which one is the preferred technique?
It's an indirect compression because here you are using the rod under the spinous process to compress it on the pedicle screw. Like what we
Right.
used to use a sublaminar hook. Rather than the hook, they are using the rod. But that's what, as Ajay said, there are 101 ways of skinning the cow. So it is one of the techniques, and people who have done it have claimed good results.
One
I
word
have
of
no experience. I've seen X-rays, but I have no experience.
One word of caution when you're using the smiley rod is the fact that bending is an art, number one. Number two, if you are when you are holding it, the spinous process can rotate. You understood? You're putting from one pedicle screw at L5 across base of the spinous process over the pedicle screw on the other side. Okay. Therefore, you might think you are compressing, but it also causes a tilt of the rattler.
Yeah.
Therefore, there could be problems with that. But anyway, they're all techniques which are basically you do a technique which you are comfortable with. As we have moved from being trauma surgeons, we are comfortable putting screws. Therefore, it's much easier and predictable rather than trying to do a different technique. It's all how you are comfortable doing it.
Yeah.
I think navigation and robotics might have added to that.
Yeah.
Yeah.
We have
So
published recent paper.
the paper from Skaggs, what he talks about is no bone grafting. He says the compression screw is good enough, drilled compression screw is good enough. And he says his patients are, I think the numbers are around 12 or 13. He talks about guided, navigated or robotic guided midline incision. There's a small, like how you do for odontoid screw. The incision is quite low down, and then you just do a percutaneous screw. And one or two patients only he has done bone grafting. Other patients he has not done bone grafting, and he claims all the patients, because the American people, they go back to sports at a very high end, and he claimed that every patient has gone back to sports.
Now, I'm not saying it may not be true, but probably they are patients without much of a gap. If you have a documented gap, then it's very difficult for you to achieve that degree of compression.
His contention again was, sir, that in a traumatic sports injury based lysis, the gap is not that high. It's only in the congenital or the dysplastic types where the pseudoarthrosis is wider, and then there is a cartilage in between which you have to remove and bone graft. But in these sports people, he said, I mean, I spoke to him after that because I had these three patients which I had to boast myself. So I was telling him, sir, we also did this, and I do not know whether fingers crossed. He said, no, they all work fine. So after seeing one of his lectures only, we did these three cases. Yeah.
Any news from Jwalant, Hriday?
I just get in.
It's 8 o'clock, yeah.
I haven't got any message from him yet. So this is what we have been discussing about, a brief about what we just discussed. So the first thing was SPECT scan, where hot spot and cold spot would mean that we have to look at the disc, as Ajoy sir said. If the disc is fine, if the disc is not degenerated, we'll probably think about lysis fixation. If there is some degeneration, then what comes is fusion. So this is a brief about how we would actually manage lysis. We all know Sachin, that is the god of cricket, who we all know has lysis. So even Sachin has lysis, and he has been passing all his career through it. So how to get an athlete with lysis back to full function is first, as we know, is to decide who is your patient. What are his requirements, how much and how quickly he needs to return to function, what is the source of pain. Now lysis, there are various sources of pain starting from the pars itself, the root, the disc, and we need to manage the source of pain and the optimal solution. So one more question that comes in is that how commonly do you prefer root blocks or injections in these patients? So how effective do you feel in terms of pain is it for these patients? Jhala sir?
Yeah, so I always, if the patient has got a radicular pain which is managed conservatively, and still the patient complains of often on radicular pain with more than, I would say, 2 to 3 months of conservative trial, then I would definitely go for a block in the young patients. I would not directly go for any surgical intervention.
So,
So the
yes.
only thing is the counseling part. When it's a sports person, maybe a different category compared to a routine patient.
And any role of these blocks in back pain in such pars defects
So
where
you can give two blocks. One is either you can give a pars block, or you can give, if there is a radicular pain for the root, then you can give the root blocks. So both of them I have given to the patients for the back pain also. But as I said, that if the back pain does not improve for more than 2 to 3 months, then I will try all these modalities.
so we all know that whenever the patient is an athlete, they all need very high level of primary, they all have very high level of primary fitness. They will want to return to function very quickly, and they are willing for aggressive rehabilitation. So time is always premium. He needs to return to full function as quickly as possible. So we need to understand the needs of athletes and children who come with lytic and lysis. So about the sources of pain, as we just discussed, there are the sources of pain in a patient with lysis. The first is the lytic defect. The second is the facet joint. The third are the discs. So degenerated disc can also cause pain, because we know that as the disc degenerates, it is bound to cause some mechanical back pain in such patients that come to us. The next are roots, where a degenerated disc can actually cause some root compression, some disc prolapse, which is actually going to cause some radiculopathy, where root blocks work wonders. Whenever there is a lysis defect is where we would consider doing lytic blocks. And also a lot of time RFs have been used by pain physician, where they would want to do RF at the lytic defect. And the last is instability, where when the lysis progresses to lysthesis is where we would want to consider instability, fusion, fixation, back pain, and probably enough strengthening of the back. So as we discussed, this is how spec looks like when we get those reports. The dark things are the hot spots, where an active means are hot spots where we would probably want to conserve them in a way that they should be resting. And we tend to know that hot spots actually tend to heal with bed rest. And according to one of the studies, 73% of active or hot spots heal with rest. And a minimum of 3 to 6 weeks of rest is what is generally advisable. We can start with 3 weeks and then a gradual isometric rehabilitation where it can help. As we discussed, MRIs would show specific edemas and defects, and will actually help in early
Can you just go
diagnosis.
back to the MRA, because it's I
So
think
I was
this
just going to ask one thing. This is also a term for a pedicle lysis. You don't have only these lysis in the pars, but sometimes these patients come with the pedicle breaks also. So this is where I feel there may be some lesion, but this is definitely lysis, not nothing more than that. But this is what I have seen also, the pedicle breaks.
So those patients you would do a more aggressive rest where there is some pedicle lysis.
the only important thing to highlight is that you need somebody who is focused to look for it, not only as a surgeon. Your radiologist also has to be used to looking for this, because these are all, if you just generally write down, they go to some other center and get a MRI done, they may miss it. Okay, high index of clinical suspicion with a a radiologist who is well versed in looking all this is very essential for you to come to a diagnosis.
And I think quite often in our scenarios where we get plates with selected cuts, we may not have that cut which actually shows lysis in the parasagittal section.
Yeah.
So as discussed, early diagnosis of an impending lysis or edema at the site of pars can be easily diagnosed with an MRI. specifically with fat suppressed that stir images on T2 images. So other things that we look at is the disc. So is it degenerated or not? The exiting route, is the disc causing any problem? Is there any compression? And the facet joints, how degenerated are those facet joints? And how can they be affecting, or may be the cause of the pain? So next are dynamic X-rays. Quite often the lysis can be dynamically unstable, probably angular instability is quite common as compared to translational instability, and those are one of those patients who have significant back pains, and these are candidates which become ideal for fusion. So CT scan I discussed defines sclerosis or rounding images are those where we know that there are chronic lysis and surgery or strong conservative management in those patients who are not sports person. We need to advocate them. We need to look at the size of the gaps. A gap more than 0.5 or 1 centimeters are something where, as we already discussed, is we should not go for a lysis repair and probably plan a fusion. So CT scans help in all these aspects and would help in defining the lysis. So a 20-year-old tennis player who had acute lysis, and we could see that she rested, and we could significantly see that there has been improvement in the CT scan, some fusion at the CT scan, and then a gradual return to rehab is what was done. So a cold lesion on CT won't heal. A CT scan with sclerosis won't heal. Where CT scan shows specific separation is when we know that it is not going to heal, and we need to manage those patients conservatively. Those are the candidates we know there will be a lot of back and forth, and they would be coming up to us quite frequently. We need to counsel them properly about specific rehabilitation through which they need to be continuously going through. And X-rays with dynamic instability may also not heal well. Once we confirm the source of pain, we know, as we discussed, injections are something that is actually going to help us reduce the pain in such athletes. So when it comes to discussing, is it parts fixation versus rehabilitation? So a cold spot with normal disc is something where we can consider parts fixation, but a primary rehabilitation protocol in form of isometric exercises for a minimum period of 6 to 8 weeks should always be a primary care or primary treatment to all patients that come to us. Rehabilitation is always going, as we discussed, 80% of the patients are going to heal with rehabilitation, and parts fixation is less and less commonly seen in our practice. Here we can see the box repair that we discussed about, the 2 screws that would actually help us hold the parts in its place. So this 15-year-old left arm fast bowler with recent right-sided flank pain on arcing back before the swing, which increased, and he had recent increase in height in training. So unilateral back pain with specific findings on clinical evaluation. So where the MRI was normal, and this is how the specs was seen, and the spec shows a very bright defect. And hence rest again helped to fuse. Here we can see that it was fusing. So this is something that has been recently come up, is to see the strength of various muscles. And strengthening of muscle is something that actually gives us evaluation about how strong the core muscles are. So dynamic strength assessment of these muscles is actually quite useful in athletes, where they can know that how strong the rotators are. Specifically strengthening the rotators and extensors and flexors is something that is going to not only stabilize their core, but also help them to visually see how important or how nicely their strengthening is going to be. So here we can see this markings, these red spots are something where they assess the strength of the muscles, and then we can actually see how they are going to improve with specific group of muscles. It may be flexors, extensors, rotators of the back. We all know that biceps and triceps, we can have some range. There's special machines now available which would actually assess the strength of each individual muscle group. So this is the gymnast who actually fell and had an acute and chronic back pain, and this is the lysis that she again developed. We see that there is some degeneration of the back as well, along with L4 lysis. So it is important to know what is the cause of this problem. Is it the degeneration or the lysis that is actually causing her the back pain? So post healing of the lysis, aggressive rehabilitation is very important because there are two problems, both the lysis and the disc that is actually causing the pain. So this is the time-tested surgery with an Indian leg spinner who actually had this surgery done when the Steffi plates even before the pedicle screws were there. So this 30-year-old international opener with the recurrence of pain, he had performance affected, he was not able to perform well. We did for off-season time and had a spinal fusion. Now with fusion, we know that why fusion, as we discussed, there is degeneration of the disc and a lysis which is seen, and hence he was able to return to full capability of working and full return to sport with his performance back to where he was. So fusion was done in this cricketer and we could get what results we wanted. So again, the racket sports, as we discussed, is one racket sports where he had two degenerated discs and a lysis, and where strong rehabilitation along with fusion is where we could return to his normal racket sport. So these are the muscle grading, where this is the red is how that athlete started with. Eventually, with time, the core strength. So there are specific groups of muscle that were tested. This is extensor, the flexors on the right, the flex on the left, and the rotators. So athletes are special, treatment principles remain the same. We need to investigate all of them to know the acute diagnosis. Yes.
There we can stop here.
Yeah.
I think, unfortunately, Jwalant could not join us. He has got an emergency, which is going to take another half an hour's time. Therefore, I just left a message to him that probably we'll have him sometime next week.
Okay.
Overall, you can conclude that slide. What is the impression of it, of your talk?
Yes, sure. So, as we discussed, lysis in athletes is a very special scenario, specifically in young kids and young athletes, because they have they have needs, because they need to be back to sport, and we need to be very sensitive to their needs. We need to work well, work quick. Treatment principles remain the same, but we should raise the bar about how to treat and when to treat. We should use all investigations necessary to accurately diagnose the lysis, and because there are very good results with conservative treatment, we should always and always primarily treat them conservatively before we plan into anything. So we should always resist over treatment. Yes.
Thank you, Rizwan,
So
for having
you
a nice
all
program. In the absence of
thank you all
Jwalant, I think it was nice of you to cover his absence.
So thank you all for joining in today. So we would be rescheduling this session with Dr. Jwalant Mehta once we have his time span schedule available. Special thanks to Dr. Abhay Nene for sharing this presentation so that we could go ahead with this. And again, thank to Dr. Jhala sir, Ajoy sir, Appaji sir to be here and to have an active discussion about spondylolysis. So The next session we all know is going to be a reschedule of this, but before we end in November, we have a very interesting session about neuroaxial anomalies in spine by Dr. Bronick. He is a neurosurgeon, a pediatric neurosurgeon in Germany, and he does a lot of neuromuscular and neuroaxial anomalies. So it is going to be a very interesting session. So both for our orthopedic spine and neurospine colleagues. So please do join us there. And all of us will be updating you soon about our rescheduled session. So thank you all for joining in today. Hope to...
Hriday, you can tell about the Rishikesh program also.
Rishikesh program.
And,
you have
yes,
to apply.
and we all know that we have our first AIMS and PSA meeting coming up in Rishikesh next month. So please be a part of it and join us, and we will be sharing you links, and you should be having those links already in your emails and on WhatsApp. So please be a part of it and join us for the first AIMS and Rishikesh combined annual congress coming up next month.
Thank you, Hriday.
Thank you all. See you soon. Yeah, bye. Thank you so much.
Bye. Good night, everyone.
Tomorrow.
Good night.
Bye. Yeah, right.